Is now being recorded.
Hello and good afternoon. Thank you for joining us on our webinar today. This is our NIH Adherence Network webinar. My name is Mike Sterrett. I work at the National Institute of Mental Health and I'm a part of the NIH Adherence Network, and I want to thank you for joining us for this, our next talk in our Distinguished Speaker webinar series, Dr. Heidi Crane from the University of Washington. I think you've picked a great talk to tune into. There's persistent questions out there about, what are the best ways that we can help to assess medication adherence through self-report questions? And are there ways to integrate those kinds of questions into our routine clinical care? And these are the kinds of things that Heidi is going to help us think about a little bit today. As I noted, Heidi is at the University of Washington. She's a physician with a master's degree in epidemiology, and she's a recognized leader in the area of assessment of patient-reported outcomes, or PROs, in the context of medical care. Heidi wears many different hats. Among her many endeavors, she has helped to develop and integrate a clinical assessment of socio-behavioral measures that are now systematically collected at multiple HIV clinics across the United States as a part of the Centers for AIDS Research Network of Integrated Clinical Systems, or CNICS. And you'll be hearing some more about that here, but this has resulted in over, I think now, 22,000 completed clinical assessments to date. So the scope of that work is really staggering. Heidi is also leading an NIMH-R01 project, which is helping to improve our understanding of how best to assess medication adherence. And she's working as a co-PI on an NIH roadmap initiative under the PROMISE initiative, which is also focused on measurement of patient-reported outcomes. And we'll be hearing much more about these activities here in the course of our talk. Among the other roles that Dr. Crane is currently undertaking, she's the Associate Director of the UW-CFAR in the Clinical Epidemiology and Health Services Research Corps, which pursues research comparing the effectiveness of management strategies for HIV-infected patients in routine clinical care. And she also sees patients in clinical care at the Harborview Madison HIV Clinic in Seattle, where she leads the clinic, the metabolic clinic. All good endeavors, and we're very fortunate to have Dr. Crane with us today. So thank you, Heidi, for joining us, and we'll turn it over to you.
Thank you, Michael, so very much for giving me this opportunity to present some of these findings. I greatly appreciate it. One of the first things I want to talk about in terms of patient-reported outcomes assessments, such as measuring medical adherence in clinical care, is why do we do that? Why do we try and measure depression, substance use, adherence, et cetera, in clinical care? And there's three reasons that are recurring themes of why this is important. The first is to improve or enhance patient-provider communication. The second is really improving clinical care and outcomes. And finally, a lovely side benefit of these kinds of efforts is how well it facilitates clinical research. So digging into these ideas a little bit further, focusing first on the enhancing patient-provider communication, it allows clinic session time to be devoted to the elements that patients and providers deem important rather than to the actual assessment of these domains themselves. It's a way of clarifying patient concerns, and a key point is that patients are more honest when they're asked about adherence, substance use, et cetera, when it's done by a clinical assessment like a computer, like a CASI or other tablet or touchscreen assessment method. There's less social desirability bias, which can be a concern, particularly with domains such as adherence, substance use, and depression. And it addresses some of the limitations of other methods of collecting this information, which we'll talk about more later, but providers are repeatedly been demonstrated to be consistently unreliable estimators of patients' medication adherence. So this is one of the ways we can address this. It improves clinical care, and the idea behind this is really to some extent based on the chronic care model, which has been shown to be a way of thinking about or visualizing care improvements for a number of chronic disease conditions. There was an IOM report that emphasized the emphasis of these kinds of approaches to chronic diseases. It's not just enough to give the providers educational sessions or educational interventions to improve these kinds of outcomes or to improve them. These have been demonstrated over and over again that the educational interventions are not sufficient. To really have an impact on clinical care requires a system-based approach, such as that advocated through the chronic care model, where you have clinical information systems, delivery system design, decision support. All of these are key elements of the chronic care model and come together when you think about PRO assessment in one sort of systematic intervention. It could be sort of thought of as a way of listening to the patient's voice, but doing it in a systematic, standardized way so that that information is usable. And then feeding the data back to the providers so that they're using 21st century informatic tools and they're using them in real time to impact care. With the ultimate goals, you could sort of imagine where this goes is these tailored, personalized, evidence-based recommendations for clinical actions to the provider in real time to impact any clinical care visit. So following up on this idea just a little bit more, this is focusing on the chronic care model, but really specifically if you think about medication adherence as the example here, what you see in the top half of this figure is a not uncommon situation, unfortunately, in many clinical care settings. There's any number of reasons why a patient might not have ideal adherence, and I suspect many of us could list some of these: substance use, depression, etc., all contribute to poor adherence among our patients. Now, if there's no systematic assessment of that, then what happens is the patient continues to have poor adherence until ultimately they develop poor HIV outcomes, such as detectable viral loads. So that's the top half of the figure. Now, think about it again in a clinical care setting where PROs or other systematic adherence assessments have been integrated into clinical care, such that while there are a number of barriers to this, structural barriers, provider barriers, etc., once you've addressed those, the figure changes, and what you see is that adherence is assessed. This leads to a system that is aware, and I don't just mean the provider here. This is bigger than that. This is the system, the clinical care system, which can include social workers, pharmacists, etc. It's not just about the medical provider, but the system is aware, which allows the opportunity to intervene before poor HIV outcomes have occurred. And regardless of what intervention that is, whether it's pill boxes, pharmacy interventions, case manager interventions, assisting with financial issues, whatever, we can come up with 92 different interventions, I think, that we could list in our heads that could possibly be useful here. But without knowing that adherence is an issue, none of these are applied. And if you follow through the figure, what you see next is that you apply the intervention and adherence is then reassessed. You therefore know either that there's poor adherence and you go through the cycle again because the system is aware, or adherence is not. Adherence is great, in which case you're much less likely to have an undetectable viral load and increased mortality rates and all of the other outcomes that go with poor adherence, using HIV as an example. And then the final reason I had listed on that initial slide about why to do patient-reported outcomes such as adherence is the way it facilitates clinical research. Incorporating PROs such as adherence into clinical care setting facilitates research that represents all of a clinic, not all of patients in care, not just those willing to sign up for trials. You have much better generalizability. You really understand the patients in your clinical care setting and what the barriers are and what the issues are. It makes for much better studies in terms of really applying to everyone and not just those who meet trial or other clinical study criteria. It includes people with depression and substance use and other issues who are often not included in trials. So these are just an example of some of the studies that we have done based on incorporating patient-reported outcomes, and we'll talk about some of these more later. But one of them I wanted to show you just to emphasize clinical research. The clinical research, or the third reason to do these PROs, is not only fun, but it's also incredibly important. And so what I've got demonstrating here on this figure, the figure on the left is the outcome for that study was patients who are at risk for transmitting HIV, and we defined that as patients who were reporting sexual risk behavior currently and incomplete condom use and at the same time they also had a detectable viral load. We used the patient-reported outcomes to look at the odds ratios for this particular outcome based on a number of different behaviors in adjusted analyses that included all of these behaviors as well as a number of clinical and demographic characteristics. And what you can see there is a much greater impact, for example, of amphetamine use on this outcome than some of the others, but all of these really had important contributions to this very important clinical outcome, and it's important not only for the patient, but also, as we've been learning over the last few years, as a public health outcome as well. And you can see that inadequate adherence is the far column on the right of the first figure, and it's also one of the factors associated with this outcome. Now, if you look at the second figure, here we've switched the outcome, and specifically what we're focusing on is, in fact, inadequate adherence. So there is, of course, one less column in the figure. But if you notice, although the scale is slightly different, the pattern of findings is very, very similar. So this is just a reminder that as we understand and address some of the barriers and contributors to inadequate adherence, we are likely also contributing and facilitating understanding and improvement in a number of other key outcomes, including some that have pretty important public health implications. Now, I hope I've painted a picture of why this is incredibly important, but unfortunately it is not without difficulty or barriers. There are actually a number of barriers to collecting patient-reported outcomes such as adherence within clinical care settings, and I'm sure that you can sort of think in your mind of several of these: staff burden, data collection, data entry, how do we get the results to the provider in real time, there's patient burden, language issues, space issues, budget issues, etc. So that there are a number of decisions and factors that have to be considered and addressed to be able to implement patient-reported outcome collection in clinical care setting, and I'll dig deeper into some of these in just a minute on the next slide. But what you should consider, as important as this is, for PROs to be able to benefit outpatient clinical care, what you really need is instruments that are relevant, valid, reliable, and easy to interpret. You want something you can put in the provider's hand and the rest of the healthcare team's hand and the system's awareness, and have that be meaningful to them. And it has to be something that you can integrate into your clinic workflow. If you blow clinic flow, you're not going to be able to continue to do this for any length of time in a clinical care setting. And finally, I think we've seen a number of different studies focused on PROs, not just in HIV, but in other chronic disease settings, that show you really want this information at the point of care in real time. It is not useful to get on the day of your clinic visit an assessment that was done 3 months earlier. It's no longer going to help you or improve the patient's clinical care. So focusing on some of these practical considerations, I've mentioned a few of these already, but there's a number of decisions to consider. And I think one of the most important, so I'll talk about it more in a minute, is generating clinic personnel buy-in. But also the space, the workflow, there's some decisions to be made about eligibility time period. Do you do it every day, every time they come in, or on windowed? These are all very addressable issues, but these are decisions that need to be made. So I'm going to talk about a couple of them in a little bit more detail here. The first one I mentioned was generating clinic personnel buy-in. And I have to say, I can't emphasize how important this one is because it helps you address many of the others. So getting support from the clinic leadership, the medical director, and the heads of nursing and program operations, whoever it is that has management oversight in the clinic, is tremendously helpful in ensuring that you can address space issues, scheduling issues, appointment issues, et cetera, and ensure a seamless integration into clinical care. But I don't think it stops just at leadership. You clearly need leadership buy-in to be able to implement PROs such as adherence in clinical care. But I think we should be reminded that the provider support, even though you often don't need the permission of providers to be able to implement in clinical care, it's incredibly important when you're changing clinic flow patterns, et cetera. So I highly advocate doing things like educating providers on the goals of the project and including and emphasizing that the goals are improving patient care and that the information is provided to them to help them with their patients. These are the sorts of things that really result in buy-in from providers and much less pushback when clinic flow patterns and other procedures end up being modified. You really need to sort of, in the early stages, consider sort of buy-in from all levels because pushback from any level can cause tremendous chaos. And then I mentioned this one before as well, the space location privacy things. These actually have gotten much easier. While privacy is obviously easiest with the paper-based kinds of patient-reported outcome collection, it's mandatory for interviewer collection, which is just one of a number of reasons why that is often not the recommended approach, but we'll talk about that more in just a minute. The electronic collection has gotten so much easier in this era of touchscreen tablets where you don't need to have a kiosk, you don't need to have a special space built up for it. You can lock it to any wall, any chair, any eye hook, anywhere in the clinic, and so there's no dedicated space needs. It just has become so much more facile than studies trying to do this electronically 5–10 years ago. And you also, there's a number of ways that you can put on privacy screens and other approaches so that even if they're doing the patient-reported assessment in the waiting room, you don't have to be concerned about some of the privacy issues that were so important 10 years ago. This, I think, is managing clinic workflow is probably the most important issue in terms of considering how to do this. And we've worked with a number of clinics across the U.S. and taken several different approaches. The clinic I work in, we actually schedule patients 15 to 20 minutes early for their appointment, and we use this as an opportunity to do a number of things, including our clinical assessment. It's also when the nurses do a fall assessment if the patient's over 50, and there's a number of we use this as our quality improvement window, and so we do a number of different things in it, including this clinical assessment. Other clinics that have longer wait times in the waiting room have found that they didn't have to schedule patients earlier to complete these kinds of assessments. It really depends on the clinical flow of your clinic, whether those sorts of approaches are needed. Clearly, just capturing people as they walk in is much easier logistically to initiate, but in the end, when you have large clinics and low waiting times, it can result in an impact on clinic flow that needs to be avoided. And then this is determining the follow-up eligibility time period. I actually think is kind of an interesting decision, but think with me what the implications are, if you will. So visit frequency varies dramatically. Some patients may be getting wound care or having acute issues, may come into the clinic 4 times in 2 weeks, while other patients only come in every 6 months. If you implement a system where they have to complete an assessment every single visit, the benefit of that is the patient expects to complete it. The expectations are clear, and it maximizes the availability of the data. However, for the patient who's coming in for wound care, it's incredibly unlikely that having the assessment on day 2, 4, and 8 is going to provide you with additional meaningful information than on days 1, 3, and 5. It adds to the patient burden. It induces additional assessment fatigue, if you will, not to mention crankiness. So there's some definite disadvantages of that approach. I would highly advocate for a preferable approach to this, if you will, is having a predetermined eligibility period. For example, if it's been 2 to 3 months, you can do the assessment, but if it's been less than that, you don't have to. The strength of this is it greatly decreases the impact on clinic flow while still providing the maximum amount of clinically useful information. However, this requires eligibility period to be tracked. We're fortunate in this era of electronic collection rather than sort of the older, much more cumbersome patient-based and interviewer-based collections, that this can often and should be tracked within the PRO assessment platform. This is not rocket science, and it doesn't need a person to do it. These are the kinds of tasks that computers do oh so well, oh so easily. And so these are the kinds of things that can be done to decrease the impact and burden on staff. So, I mentioned a few of these points. There are several different approaches to collecting patient-reported outcomes, and 10 years ago, probably these were sort of equally divided among them. You saw paper-based, you saw electronic collection, and you saw interviewer collection. Interviewer collection has clearly become less and less commonly used, and appropriately so. It's incredibly time-consuming and expensive. There's always privacy concerns. And finally, there's societal bias issues. It's much harder to tell an interviewer that you haven't taken your meds for 3 weeks or that you were using crack last weekend than it is to tell the computer or the paper. The interviewer is probably by far the least best approach for implementing routine patient-reported outcomes such as medication adherence in a clinical care setting. This leaves us with two reasonable options, an electronic collection and paper. Now, paper-based collection is clearly the cheapest to initiate and the easiest to start. However, in the long run, it results in much more patient burden, and the reason for that is paper doesn't ever allow you the opportunity to do skip patterns. It doesn't ever let you focus an assessment on just what's clinically relevant. So I'm going to take an example from substance use. If the patient has already told the assessment that they've never used cocaine or crack, you don't then want to ask them if they've used cocaine or crack in the last 3 months. You want to skip the rest of the cocaine crack items. And paper-based doesn't give you that flexibility. When you try and do those kinds of skip patterns on a paper-based format, you always end up with missing data. Patients don't understand, they go to the wrong place, there's always data quality issues. And I think the most important downside to mention for the paper is it doesn't score it in real time. It's much more difficult and cumbersome to get paper-based collection into the hands of the provider as they're going in to see the patient. So while paper-based is cheap and easy to implement and can be used for clinical research despite some data quality concerns, it is much less useful if one of your target goals is improving clinical care. Which leaves us with electronic collection. Clearly, electronic collection is more expensive in terms of startup costs. However, it's already been demonstrated that although the initial costs are more expensive, if you're doing any kind of numbers at all, it becomes much cheaper over time than paper-based because, again, it has less staff burden. There's no one who has to score it. There's much less impact on flow. It's much more efficient. Even without the skip patterns, it takes less time for patients to complete an electronic than a paper. And finally, and I would say not unimportantly, patient preferences have repeatedly demonstrated that patients prefer it. So I think I've sort of mentioned these, but many of these points, but I think a key point to remember is how much more feasible electronic collection has become in the last few years, not only because the costs of the hardware have dropped a log figure in the last 10 years, and the use of touchscreens have addressed some of the early studies that demonstrated concerns for older patients who were uncomfortable using the mouse, but we all have been using computers more in our everyday life, including checking out at the grocery store, at the ATM, etc., that this is just becoming more and more routine, and for that reason, patients prefer this over other modes, not do it at least in part, at least in some studies, because it's faster and patients like that. There's less patient burden. And there's advantages over interviewer, both in terms of costs and in terms of reporting potentially stigmatizing behaviors. And there have now been a number of studies that have demonstrated the feasibility of this type of approach, even in a number of mentally ill or other difficult to reach patient populations, that this works. And it eliminates all of the problems with the data entry step in terms of scoring, delays, costs, errors, etc. It just takes the human error out of many of those aspects. And it allows conditional branching and complex skip patterns that has a tremendous reduction on the patient burden. So I think those are some of the key points, the key advantages of electronic collection, and I would actually add one more that we have found that our providers really like, and that's the safeguards that can be added. So for example, when a patient reports that they have been feeling over the last 2 weeks like hurting themselves most days, hurting themselves or others most days, which is an item on the PHQ-9 and depression inventory, my pager goes off in real time, and I would argue more importantly, the head case manager's pager goes off in real time, and that patient is assessed for safety before they ever make it out of the clinic. And we've found that those sorts of interventions are incredibly valuable to providers and do a great deal to endearing support from clinical care, and I would argue really have an impact on improving care in our clinics. So one question about this is what is it we should measure? And we were interested in what some of our key stakeholders thought we should be measuring. So we had both patients and providers do a number of ranking exercises, and these are providers from 8 states and clinical sites across the United States. as well as about 75 providers and about 65 patients. And we said, what is it important for your provider to know? What is it that we should be telling the provider that you aren't already or that's getting missed? And one of the points I'd like to point out is that both patients and providers consistently, and this was across a number of subgroups, consistently ranked medication adherence and depression as key priorities for improving clinical care. Interestingly, I thought some of the barriers to adherence were ranked more highly by providers. Some of my patients didn't think I needed to know whether or not they were using crystal, and I would disagree with them on that point. I would argue that I do. But that said, providers consistently ranked many of the adherence barriers, such as substance use, quite highly as well. So one question we're going to move into for just a minute is then how do we measure adherence in clinical care settings? And so we've actually been doing a little bit of work that is focused on how adherence has been measured across a number of chronic diseases. And this is an interesting area in that adherence measurement work has often been siloed. There's systematic reviews, there's studies that focus on this disease or that disease, but there's not as much as I would have expected that's cross disease looking at these. And one of the findings is that while HIV has the widest array of instruments and items, formats, it also has the greatest evidence supporting the use of self-reported adherence item, but it is definitely not the only chronic disease that has demonstrated the potential clinical benefits. So we've been looking at the various ways adherence behavior items have been addressed in a number of chronic diseases, and there's really a vast array, a complex array of items that have been used. And incredible complexity was noted in some of the chronic diseases in how it's been measured. And a real lack of consistency across diseases in terms of what different diseases are being approached. So I think that's interesting in that it is in contrast to HIV, which has been taking more and more simple, brief approaches to measuring adherence. So I think when we're thinking about clinical care, we really should emphasize some of these briefer, more focused measures. And so what I'm showing you here is this is a slide demonstrating some analyses with viral load as the outcome and looking at different brief adherence items. And so if you look at the top one, that's a single item measure of adherence called the self-rating scale. And if you look across, let's take the adjusted analysis column. This is adjusted for clinical and demographic characteristics. What you see is the odds ratios march nicely up the adherence severity based on that single item. It behaves exactly as you might want it to. And we did similar analyses for a single 4-day item that has been commonly used by ACTG in a number of studies, a last weekend item that similarly has often been used in ACTG items, as well as missed dose items and a visual analog scale. And I think one of the key findings from this study was that the single self-rating item worked incredibly well in terms of measuring and predicting viral loads, current and future viral loads. But even that said, some of the less well items still worked quite well. Now, while I really like these very brief, the single item self-rating adherence item, I think is fabulous. I do point out that the disadvantage of that, to be fair, is that it can miss some of the complex patterns of adherence behavior. It is not the end-all, be-all. On the other hand, it is so incredibly brief that it is often very easy to facilitate implementing that kind of a measure into a clinical care setting. And the reason you do that, the goal here is really to focus on a more targeted discussion of patient needs with real-time adherence intervention before the patient suffers virologic failure and therefore, potentially develops resistance and all of the complications thereof. And I would argue that essentially virtually any of these measures can help you reach that goal, but we repeatedly demonstrated that the data from the self-rating item really was a single item that was able to help do that in a very nice way, consistently across a number of disease populations. Another commonly used measure of assessing adherence is asking patients about the number of doses they missed. The 4-day item has been frequently used in older studies, and recent studies have really shown that maybe some of the longer time frames, the 2-week and the 1-month items, might be a better way to go. So we took a look among 1,000 patients who answered all of them on the same day in a randomized order. We were curious how this looked. And what we see is that there may be greater over-reporting with the 4-day. If you take a look at the figure on the left, the 4-day item really appears to be above where the fitted line is in relative to all of the others. We think that's because there is some over-reporting with the 4-day item that we're not necessarily seeing with all of the other items, which I think is a fabulous thing. I think there's a lot of concerns about societal bias and other issues, and I suspect we're putting just a little too much emphasis on that. When we give patients a longer window, they feel the freedom to report that they've missed doses. So we then did a nested regression where the outcome again was undetectable viral load, and we looked at this a number of different ways. And in adjusted analyses, adjusting for age and race and a number of clinical and demographic factors, the 14-day item had the highest R-squared, or was the most highly correlated with this, with our outcome of undetectable viral load. We did this several different ways, including starting with other measures and adding the 14-day item, and it consistently ended up that the 14-day item was the most strongly correlated with our outcome of undetectable viral load. So I think I've presented a lot of information and a lot of studies, most of which were not mine. So I thought maybe I'd spend just a minute talking about what we've been doing in Phoenix, which is a cohort collaboration of a number of clinical sites across the United States. We implemented a patient-reported outcome or a clinical assessment into clinical care at a number of different sites across the U.S., and including adherence, depression, anxiety, a number of the key domains that we thought was either important for clinical care, clinical research, or ideally both. We used the PRO platform we use is a web-based survey software application that's open source, so there's no cost to use this. Patients complete the assessment on touchscreen. Patient results are typically given to the provider before they enter the clinic appointment on the same day. We do that in several different formats depending on the clinic flow and the electronic health record of that individual clinic. We do that at some sites on paper and some sites electronically, again based on whatever the clinic flow is at that site. We do this in English and Spanish, and the platform tracks the time since they last did it, whether they're eligible or not, as well as notifying patients and notifying case managers of suicidality, eligibility for studies, and a number of other very helpful electronic applications that have been built into it. This is what an item might look like. They see one item at a time. There's large radio buttons that they can use. If they don't want to answer an item, they can click next. If they mark an answer incorrectly, they can easily change it. And we work very hard and have really focused on avoiding disrupting clinic flow, finding pockets of visit time when the patient is waiting. And in a number of our clinics, we just were able to implement it without changing clinic flow because there was that much time in the waiting room. In others, we had to rethink the appointment scheduling and make some changes. But it really depends on the clinical flow setting and has to be individualized for the clinic. No two sites have exactly the same clinical flow approach. Even with sort of thinking this out, this was definitely a moving target. This is an example from one site of the modifications we made. This is from my site, the University of Washington. We implemented it. 4 months after we implemented it, we did some reordering of the items because we wanted to make sure that the most clinically relevant were completed soonest, to make sure that the results were in the provider's hand. And after we made that change, we track how often we have the feedback in the provider's hand before they see the patient, and we're consistently over 95% of the clinic visits at this point. By the time we'd been doing this 5 months, we were being harangued by the case managers who said, this is our terrain, we want this information. And so this particular clinic had a paper-based feedback system because they weren't using the EHR and the appointments as often as we'd like. So it automatically prints a second feedback for any patient who is at risk on the domains that the case managers or social workers were interested in. And we give that to the patient's social worker on the same day as the clinic visit before the patient leaves. So if there's an action item that the provider can take, they have that opportunity while the patient's still in clinic. And this is somewhere in the realm of 70% of our patients have at least one of these at-risk criteria, including inadequate medication adherence. And we continually expand our options, adding Spanish and other things as appropriate for our clinical care settings. I think I've talked about many of these barriers in terms of technical issues, clinic flow, et cetera, so I think I'll just skip this one. One of the points I made earlier was really emphasizing how important it is to get clinic buy-in. And so one of the studies we did early on with our very first clinical site where we implemented adherence is we started it as a waiting room study where we had the patients complete it. Before we implemented it in clinical care, we had 500 patients complete the assessment. At that point, we didn't give the feedback to the providers. We were just working out the kinks in the system. However, of those 500 patients, 62 of them reported incredibly poor adherence, missing multiple doses in the prior 4 days, clearly poor adherence. And so we reviewed those charts to determine if the providers knew about that or what the providers said about adherence. And among those 62 patients, only 17 of them did the provider document that the patient didn't have ideal adherence in any way. 25% of those charts had no mention of adherence at all, and probably most concerning at all, at least for me, was a third of the time there was documentation from the same day that the patient had poor adherence from the provider that the patient's adherence was good, missed no doses, 100% adherence. Some other documentation in the chart note from that same day that the provider thought they were adhering perfectly. In addition, among those patients who the provider noted the inadequate adherence, we also found that a huge number of them had barriers to adherence that were not acknowledged by the providers. So even when the provider caught that the adherence wasn't ideal, they were often missing some of the key barriers such as substance abuse, relapses, and depression that were not known about. So we implemented this in Phoenix at a number of sites, and then we did a great deal of qualitative and observational workflow studies to determine the impact and determine that we could do this well and sustainably without interfering with clinic flow. And this included interviews with provider and staff about the system and how well it worked, and we were heartened by how often we heard certain themes from the providers, such as it really serves as an icebreaker that it was not disruptive to clinic flow and that it promotes an awareness of these under-recognized or unrecognized issues. That came up recurrently, consistently from providers, and particularly for both medication adherence and at-risk alcohol use. Providers just didn't know how often patients weren't taking their meds or weren't taking them after drinking or were drinking much more than they thought. Those were common recurring themes from these interviews. Here are some of the quotes that you can take a look at if you're interested. And again, it's that idea of the recurring theme. He drank a lot more than I realized. I didn't have any idea he was not taking his meds. It was a real nice way to start a conversation. It was a nice tool to engage around real issues. We did patient usability tests. And the three recurring themes from those qualitative interviews was that it was useful, relevant, and important. It was a valuable experience by the patients to have this implemented in clinical care. Now, that said, it's not without challenges, and some of the key challenges are completion time variability. The patient on the tablet, the same patient A may take much, much longer than patient B, and that has to do with inherent speed of the patient as well as skip patterns and risk behavior. Some patients get asked more items based on the skip patterns. That is difficult to manage in terms of clinical flow and is a key issue that's hard to address. Other ongoing challenges are every clinic we work with has their own electronic health record, and really trying to work well with implementing in seamless ways where the information gets fed into their medical record in a way that's most useful to providers, gets put in the provider's hand before they see the patient. And we're in early work doing some interesting pilot work, working on some of the patient web portal and other electronic implementation systems. So the next study we conducted was in this same clinic. I presented some results from before we implemented feedback, which we used to get buy-in from the providers. We therefore had PRO data both before the provider feedback was started and PRO data from patients after the PRO feedback was started. And we again reviewed the charts from those patients, and the chart reviewers didn't know whether or not the provider received feedback, to look at whether providers were documenting these issues and or whether they documented any action in regard to these issues. And what you can see on this slide, and there's a lot of information on here, but I'm just going to highlight a couple of columns. The white columns are before feedback, and the purple columns are the data after feedback. And this is among patients who have each of these behaviors, so among the patients who have moderate to severe depression, et cetera. And what I want to point out is, first, that in the top figure, what you see is that providers were in some way acknowledging adherence pretty often, even before feedback. But if you look at the third pair of columns, what you see is among patients with clearly crummy medication adherence, providers were documenting it inaccurately. So the third set of columns is how often providers were documenting excellent adherence or missed no doses among patients who weren't taking most of their meds. And so you can see that this is a place that the feedback had a really substantial impact, essentially greatly reducing how often providers get it wrong, how often they think the patient is doing great, but in fact are taking basically very few, if any, of their medications. And similarly, alcohol use, as came out with the qualitative work, at-risk alcohol use was another place where the feedback had a real impact on provider awareness and documentation. The provider just wasn't aware of how often the patients were drinking large amounts of alcohol. And so, in summary, what we found is that implementing the feedback for PROs in clinical care in an HIV clinic really improved the accuracy of providers' assessment of adherence. It identified a lot of at-risk alcohol use that was being missed. It had some impact on actions to address alcohol use and adherence, and it identified a larger amount of substance use. Now that said, I guess I would argue that this is a necessary but not necessarily sufficient approach to improving clinical care, in that many of those columns I'd like to see much higher, much closer to 100%. And so I would argue that in some ways this is a first step. It improves the provider's awareness, but doesn't necessarily tell them what actions to take. For some domains, it was more effective. For example, we had very little impact on sexual risk behavior, responses, actions, or documentation for providers. The feedback really wasn't a good intervention there, but it really was an important and useful intervention for some domains, such as adherence and depression and alcohol use. And one last point I wanted to make here, although the data I'm presenting is really about provider behavior and actions, this should in no way minimize the importance of case managers and other members of the healthcare team. There are other studies and other aspects of that that we find very interesting and are working on, but the fact that I'm presenting the provider behavior should not minimize the importance of those other healthcare team members. We found that we could collect the instruments and domains that I mentioned in the earlier slide in Phoenix in a median completion time of 12 minutes. Now, that 12 minutes not only includes all of the domains and instruments we've already talked about, but it also includes additional instruments for 3 extra studies. So I think it's entirely feasible to do this sort of comprehensive type clinical assessment that not only includes medication adherence, but also many of the key barriers to medication adherence, such as substance use, depression, et cetera. And it's reasonable to do that in an 8 or 9 minute sort of type assessment. The fact that we're longer than that is, again, because we have not only clinical care, but clinical research goals included in this assessment. So I think in terms of thinking about some of the lessons learned, we've demonstrated that we can implement patient-reported outcomes in HIV clinics. These are large, busy, multi-provider clinics, and we've now had 22,000 assessments completed by patients with HIV at the time of routine clinical care appointments. So these are not patients coming in for studies. This is part of care, implemented as part of clinical care. We found a huge prevalence of poor medication adherence, depression, active substance use, and high symptom burden that suggests there's a real need for measuring these, assessing these kinds of outcomes, and then addressing them. We found that providers like this and particularly they liked some of the additional features of the electronic collection, such as the pager notification of suicidality, making sure when our patients are reporting those sorts of things that they get assessed in real time and that they get resources and it gets addressed. I think is incredibly valuable to providers. That the qualitative approaches really validated some of the quantitative findings and really was very useful in clinical care settings to make sure we understood the impact we were having on clinical flow and that we were taking the best approaches we could. And that what we see is dramatic differences in adherence rates when we compare the results of the PRO assessments to provider progress notes if they don't get the feedback. Again, we were able to initiate this project because of a very supportive administration across a number of clinical sites, but also because we demonstrated repeatedly the clinical need at each step of the way. And once we integrated in each of these clinics, we worked really hard to maintain provider support. So working very hard to make sure we didn't disrupt flow is a key point, but then also making sure when providers and staff were conducting other studies or wanted to be notified for enrollment, any additional feature we could add to this to make it not just another thing in the clinic, but a thing that everyone valued was a key target. And then maybe most importantly, we frequently update our clinical sites as to the findings. How much depression did we detect after the first 100 patients, the first 500 patients, et cetera, making sure that the providers and clinic staff feel like an involved, integrated parts of these approaches. And so this leaves, if you will, sort of recommendations, next steps. We've demonstrated the feasibility and I would argue the value of incorporating these kinds of clinical assessments, including adherence into HIV clinics. I think that there's enough available data that to some extent you can measure adherence in any number of ways and it will be of value to you, but that you don't have to have the long, complex measures incorporated in your clinical assessment to have real value. I think there's enough data on these single item and very brief adherence measures to be comfortable with a self-report, with the self-rating item, these very simple, not complex, not high patient burden instruments provide a whole lot of really valuable information that can be used to improve clinical care. And I think one of the very fun things we're doing right now is we're taking what we've done at these academic health centers and we're integrating clinical assessments into some community health centers. These are many of these are rural clinical care settings with not a lot of resources, and we're implementing these clinical assessments for both their HIV-infected and uninfected patients, and again, sort of replicating and demonstrating that, again, we're having an impact and that it can be done in these low-resource, non-academic, non-specialty clinic kinds of settings and have an important outcome, both for clinical care, most importantly, as well as clinical research. And then we're also, currently what we're doing is a lot of quantitative studies evaluating or examining different ways of giving the feedback. So how do we provide this information to providers as well as the rest of the healthcare team to maximize impact, to maximize the likelihood of an action or an intervention? How do we have the greatest impact with the feedback and where do we go from there? And again, I think I said this already, but I would argue what this study shows is, these studies show together is that these kinds of clinical assessments are incredibly important to understanding where your clinic is and improving clinical care, but in many cases they're not sufficient. They're a starting point, and you then have the information necessary to develop and determine where you need additional interventions and additional efforts to improve clinical care in your patients. And then I didn't really talk about some of the next steps, but some of the work we're doing right now through the Promise Network is computer adaptive testing, so ways of shortening various instruments, ways of really focusing on what you need to know without losing the information available in those instruments. And we can talk more about that if people have questions. I'd be happy to explain it. This is, many of these studies were not done by me. This is the work of a fabulous group of colleagues. We have incredibly supportive clinics that we've worked with and incredibly supportive networks. Phoenix, Charn, and Promise have all been lovely, and we have had an amazing support from the NIH in terms of NIMH as well as OBSSR. We are just incredibly fortunate. I think that's more than enough. Can I take any questions?
Yeah, just hit one more. There we go.
There we go.
Thank you so much, Heidi, for that excellent talk and for sharing this very impressive and very exciting work, with our group. For our webinar viewers, as you can see here on the screen, we do invite your questions. And if you do have a question, feel free to send it to our email address here, or you can tweet a question to us as well on Twitter using the hashtag NIH Adherence. We'll do our best to funnel those questions here to Dr. Crane. So please, feel free to contact us. I think while we're waiting for the questions to come in, I'll go ahead and, take this opportunity to get our questions started. And so, Heidi, just to be clear, so the system, it's remarkable in the sense that you're using this downtime that patients might have in the waiting room, systematically collecting these patient-reported outcomes around substance use, adherence to medications, and then feeding that in real time into these electronic health records. So that's available for not just the clinicians, but the entire comprehensive care team to access and then to utilize. And I guess I'd follow up on just one point that you were making at the end there. So it seems like from the work to date, we're seeing good evidence that this system is changing some of the documentation in terms of the clinic providers and whether they're recognizing that there might be a problem with substance use or there might be a problem with medication adherence. But in terms of that next step, to see if that information which is actionable, is producing action that then affects things like adherence or reduces substance use or improves treatment outcomes. That's work that is still coming.
That's right. So at this point, we have demonstrated that we have and can change provider actions. So we know for alcohol use, for example, that providers who get the feedback for patients with at-risk alcohol use are more likely to refer the patient to the case manager or health educator. There's more likely to be a referral to AA. We know that for certain domains, with the exception of sexual risk behavior that we have no impact on, that for most of the other domains, we know we have demonstrated provider actions. They are referring more. There are, different actions for different domains. With alcohol actually being a really nice example of one where we've demonstrated an increase in referrals, an important increase in referrals. So the next studies are, can we then demonstrate that in having providers more involved, having case managers more engaged, having them do some of these interventions, does that then change patient outcomes?
Yes. Yeah, I know. So you already have interest here from the provider teams, the care teams. It seems the patients are responding well to this.
Yeah.
Changing the way that people are responding. It'll be fascinating to see if you can affect those actual patient outcomes, those clinical and treatment outcomes.
Right.
I'm also wondering if you have any sense or evidence to date about how patient use of this system might, if there's any kind of reactivity to the system, in the sense that, so there's an idea that, computer-assisted assessments are superior to an in-person interview. We talked a little bit about that. But here, these patients must realize that they're reporting data that's then going to get seen by their doctor, going to be seen by their social worker. And in some cases, it sounds like that's prompting a response. A mention of suicidality brings a swift response from the care team, right?
Sure.
So I'm just wondering if, those kinds of things have the potential to affect how people then self-report, things like substance use or suicidality, down the line,
Right.
Do people learn, oh gosh, I shouldn't report this because they're going to come and get me?
Right. Well, it's an incredibly insightful question. So I have two answers to that. One is when we started it at the first site, we didn't give the feedback to the providers, and so we compared rates of reporting in the 8-month period before feedback and the 8-month period after among people who took it in both windows, and we get similar rates. So the first thing is I don't think there's any evidence that when we changed the system so that providers were getting feedback, and we told patients, providers are going to get this information. We did not see a dramatic drop in sexual risk behavior, in substance use, et cetera. So I don't think just the idea that the provider may get this had a big impact on our reporting rates.
Okay.
I think, so that's the first question. I think your question about the suicide is incredibly insightful, though, because, I presented our qualitative work and our findings, and it's been incredibly positive, but the one place I have gotten pushback from patients, the one place I've ever gotten complaints or crankiness is really about the suicidal intervention. Patients, the only place I have ever gotten sort of really seriously cranky patients is the immediate, are you safe at home? Do you know the numbers? Do you have a plan? Those sorts of interventions. And I guess I am comfortable with the idea that I think that this is important, and making sure that the patient knows they have resources, et cetera, that I'm willing to live with a little crankiness factor over that one. And I don't get it from anyone else, even when we are in their face asking, do think aloud, tell me what you're thinking after every item, et cetera. We don't get a lot of pushback. It's really well received. And so that's the one place we get any, and I think I'm just willing to live with that because it's such an important thing to know. I really want to know, and so if it annoys them a little, I may be okay with that.
Yeah, no, you're erring on the side of safety there.
Yeah.
And looking out for people's, safety and well-being. We do have a question here from Twitter, and of course you were talking earlier about different approaches towards assessment, paper, electronic, and then interviewer administered. And our question is about the potential to use mobile devices to make some of these inquiries. And here you have a clinic-based system. You've got the tablets in the clinics, but I suppose that one could do this, maybe in the real world through people's text messages or some kind of app. What's your thinking about that?
So I think that's a fabulous idea, and we played with various versions of it. We chose. It was a very purposeful decision to do this as clinic-based, and the reason for that is we have many of the patients who don't have access to a computer, who don't have a smartphone, are many of the patients that we're most trying to make sure we capture. These are the patients who don't make it into the trials. These are the patients that fall through the cracks, if you will. So we purposely did it as a clinic-based system to make sure we were all-inclusive. Everybody in our clinic eventually shows up in clinic. Now that said, I actually think one of the future directions, if you will, is to have a combination. So if you have a clinic-based system as your starting point, you're generalizable, you're comprehensible. But if you then add some of these mobile technologies, if you then add the opportunity for patients to complete it at home if they wish before they come in, et cetera, that has the ability to decrease the impact on clinic flow. But as long as you also have the clinic-based system, you don't then start excluding those who might otherwise fall through the cracks. Mm-hmm. So I think it's fabulous as an add-on. I don't think it should be the primary.
Okay. Interesting. Here, so you've primarily been working in the context of HIV treatment and these comprehensive care clinics, and I just wonder if you could comment a little bit about, you don't just work in HIV, and I wonder if you just could make a special comment about the relevance of this for other care settings.
Right. Well, so we started with HIV, and so these were academic specialized clinics that focused on chronic disease patients. But one of the things we are currently doing, that we currently have this fabulous opportunity through OBSSR, is implementing clinical assessments in a number of community health centers. And so this is occurring right now in South Carolina, in very rural clinics in South Carolina, in Baltimore, and in a number of sites, and that's going incredibly well. I don't have a great deal of data on impact because this is a more recent project, but I can tell you that we have gotten a lot of patient and provider support and buy-in that they think this is clinically relevant, clinically important, and going to improve clinical care for their HIV-infected and uninfected patients. Substance use isn't just restricted to those with HIV, many of these key factors are not just those with HIV, and there's no reason that it has to be sort of segregated that way. And in fact, you know, from a platform standpoint, it's actually very easy to have the very same platform, the very same system, and it does a skip pattern. So if patient's HIV uninfected, it skips certain domains that are only relevant to those with HIV, and if it's patient is HIV infected, it can add additional domains. So we can actually target instruments to those that are most relevant to them, and we can do it at the level of the platform, again, to make things as seamless as possible for these community health centers, which have been so gracious to allow us this opportunity.
Nice to see and to hear. There's another question here, and it's about your self-report approach. You know, this is all about collecting data from the patient, you know, and although it's done electronically over the tablets, it's, you know, asking them this question. And there's certainly been, you know, questions raised about the validity of that approach relative to other approaches for assessing adherence. Might be looking at trying drug level or some kind of, you know, biological outcome. You've got pretty good evidence here of the utility of self-reports, right?
Yeah.
Just, you know, remind us what you think about the utility of that.
Right. So I think there's a couple of issues. The one is feasibility. While there are objective measures of adherence, many of them have their own issues, but most of them are not feasible in wide scale across clinical care settings. So that's issue one. I think issue two is that self-reported, for example, medication adherence has really gotten a bad rap. Yes, there is some over-reporting, but I think there are things we can do to minimize that, such as not doing it interviewer-based, but letting them tell the tablet that they've missed doses. So while there is a little bit of self-reporting, I actually think when a patient tells you they're not taking their medications, that is incredibly useful information, and it is information that Dr. Bangsberg and other incredibly brilliant colleague investigators have demonstrated repeatedly that providers don't get, that they don't have, that they don't know unless you do a systematic approach. So I would say that's the second thing. And then I guess the third thing is we have another study that I didn't present that actually looked at self-reporting clinical care, and actually we did some unannounced pill counts within a clinical care setting, which is a feasible nightmare that I will probably never do again. But I think the take-home point from that work is that we sort of demonstrated again that the over-reporting of adherence has really gotten too much of a bad rap, that this is an incredibly useful measure. It's so much more cheap and feasible than these pill counts and many less data nightmares, and it's available in real time. But more than that, they really are incredibly highly correlated, that you don't have to go through some of that incredibly cumbersome and unfeasible measures to get incredibly useful information.
Well, I think that we will have to close there, and I know that all of our viewers will join me in thanking you, Dr. Crane, for sharing your work with us today. Very interesting, very important work. And if anyone has a request for the slides, you can send that to the email address here. You'll also find the webinar posted in time to our website. That's if you Google the NIH Adherence Network, you'll find that. Otherwise, we will look forward to seeing you when we have our next scheduled webinar, which I think is under, we're currently getting under, it's being scheduled as we speak. Anyways, all right, thank you, and thanks for joining us. Take care. Bye.